Hello, doctors. Good evening. Can you see the screen already?
Yes.
Okay. Hello, everyone. I'm Dr. Fernando Sanguyo, and I'm here to present my family case today. And it's entitled All by Myself, the second time around. My objectives is to present a case with multiple medical problem. To present another is to present a criteria for admission to a healthcare program, and to present tools used for family assessment. To continue monitoring the patient and their condition, and to provide a comprehensive wellness program for each member of the family. So for our index patient, MMP, a 49-year-old female widow, works as a fruit retailer wholesaler born in Candaba, Pampanga, but currently residing at Olongapo City, and with a chief complaint of nape pain. So for the history of present illness, the patient, 1 year prior to consult, patient noted an on and off back pain, nape pain radiating to the occipital area of the head, rated as 3 to 4 out of 10. No exacerbating factors, but no consultation done also, and takes only pain medications, which gives relief. And no consultation done. This usually happens once every month, which was usually relieved by pain medications or sometimes relieved by rest. Until 1 week prior to consult, patient was again complaining of recurred nape pains, characterized as the same characteristic as the nape pain 1 year ago, and not exacerbated by any movement. No noted headache, fever, vomiting, numbness of extremities, nor trauma involving the head or the neck area. The persistence of recurred knee pains prompted consult already. For the review systems, there's no notable symptoms uh, regarding this. And for the past medical history, the patient is known hypertensive for already 5 years, non-compliant with taking amlodipine 5 milligram tablet once a day. Diagnosed with dyslipidemia just this year, and started on atorvastatin 40 milligram tablet once a day at night. And diagnosed with degenerative osteoarthritis after a history of fall last April 2021, where the patient sustained soft tissue contusion on gluteal area and knees, which caused the patient to have difficulty on walking due to pain. And consultation done, and was also referred to orthopedic service, where she was advised to have a knee replacement surgery, but the patient refused and opted for medical treatment or for pain relief. OB history, patient is annually gravid, started when NARC at 11 years old, regular 30 to 32-day interval with 3 to 4 days duration, uses 2 to 3 moderately soaked pads per day with additional associated dysmenorrhea. Personal social history, patient is a non-smoker, non-alcoholic beverage, no known allergies with no previous admissions or confinements nor surgeries. Social environmental, lives in a rented 2-bedroom apartment near fruit stall and a flea market, added lightings and ventilation, drinking water from a purified refilling station, and waste disposal collected usually 3 times a week. With the family background or family history from father's heart problem and bone cancer from the maternal side. For the physical examination, noted blood pressure, elevated blood pressure at 160 over 100. Other vitals are null. With a weight of 83 kilograms, with a height only of 152 centimeters, and an BMI of 35.9, with a waist circumference of 44 inches. For the other physical examination in the neck area, there's no tenderness or swelling on the neck area, with the full range of motion of the neck. And neuro findings, no neurological deficits noted with GC15, and with full range motion also of the shoulders without any difficulties. For my assessment, it's a musculoskeletal chain, probably with psychosomatic component, with hypertension stage 2, obesity class 2, degenerative osteoarthritis on both knees, and dyslipidemia. For my differential diagnosis, MMP is a 49-year-old woman with multiple particulars and an obese patient presenting with chronic history of neck pain with radiation to occipital area. 3 to 4 out of 10 in severity without any tingling or burning sensation on extremities with noted full range of motion of neck and shoulders without any exacerbation on movement. Start with cervical degenerative disc disease. We rule it in due to nape or neck pain, and also could be from obesity. And also, since the patient's already died degenerative osteoarthritis on both knees, probably other joints could also have this degenerative problem. But we rule it out since there's no weakness in the arms and hands, no sharp or shooting pain on arms, hands on movement, and there's no worsening of pain when there's any movement. Another one would be a cervical fracture. We ruled it in due to a nape and neck pain, but we already ruled out since there's no history of trauma, and the patient can do full range of motion both on the neck area and on the nape, on the shoulder. So we continued her medications with amlodipine and added some losartan and atorvastatin. And for the pain relief of paracetamol, tramadol, and also in glucosamine and chondroitin capsule twice a day, which was given by the orthopedics service, and an eperisone tablet 3 times for 5 days for the muscular strain. So for the criteria for admission to the family healthcare program, the patient has a medical problem which requires periodic follow-up, monitoring, and counseling. And accessibility, the patient can be easily reached through virtual consultations. Patients have accessible nearby clinic with laboratory if any workup or diagnostics was needed. For the tools, the family structure, so on July 30, 2021, for my genogram, simple lang po. Our index patient, Marie, 49-year-old, is a hypertensive. So born, mother already died. Nag-start po si Carmen, yung mother niya, early na die due to bone cancer. And then, yung father niya, since nung namatay, nag-asawa ng iba, and then umalis na siya. So after that, naiwan na lang siya mag-isa sa uncle niya. Tapos lumipat na siya ng after nung medyo nagkaedad na, lumipat na siya ng Olongapo from Candaba. And then pangasawa siya si Jonathan, pero namatay din. Jonathan died from the complications of CKD. After having dialysis for about 4 to 5 years, and that doesn't have any an offspring. They solely adopted Angeline, which yung sila na lang po yung makama sa bahay after. So the source is the patient and in Olongapo City. And family stage, family with young children, the family dynamics. So yung index patient po, there's no problem with the relationship with her husband, her mother, and dun sa adopted child nila. Although yung adopted child nila hindi na adopted siya, yung father niya yon, since nung umalis po, wala na siyang contact and hindi talaga sila in informed. So yun, merong anak pala outside na 6, although hindi alam nung index patient kung lalaki or babae or ilang taon na sila. So yun. So they live together, and since dalawa na sila, yung adopted daughter at saka si index patient, so in good terms naman. So dun sila sa bahay nila. So yun. So with family profile, with the index patient is a 14-year-old high school graduate and lives with adopted child, and AP's adopted daughter, a 9-year-old grade schooler. So for the family Apgar, so yun, since ang sabi hindi talaga siya simula pa nung sa simula, yun nga, mag-isa na siya since iniwan siya ng father. So hindi niya masagutan yung dalawa. And sa ano na lang, yung dito sa GAR, yan, yung nasiyahan pag tinatanggap, suportahan, and yung iba din. So all in all, the total 6, so moderately dysfunctional. And for the scream, so ito, we are helped by friends and other members of the community. So yung sa community naman na is almost may mga relatives naman siya doon. So sila yung parang tumutulong sa patient. Tapos kung may mga problems, so lalo na kung may medical problem na kailangan puntahan, ganyan, since medyo nahirapan siya maglakad. So community helps the patient or the family and the religion, and economic, medyo one siya kasi ang sabi niya nung nag-pandemic, since fruit vendor siya, medyo nahirapan na raw sila kasi humina yung tapos kahit wholesale yung mga benta niya from restaurants, medyo mahina na kasi humina din yung mga restaurants na nag-open since ng pandemic. So medyo nahirapan sila dito. Education, patient is able to naman po understand kahit pa paano yung illness niya, and medical, see access to medical health community. Strongly agree naman siya kasi meron siyang relative na nurse, so mas nadadalian siyang magtanong kung may mga concern siya. Yan. So all in all, that's 12. So moderately inadequate family resources. So yan. So social, good interaction with daughter and other community members. Although iba yung sa siblings, not known to patient. Religion, so unable to go to church recently due to difficulty in walking, and dun sa pandemic. And economic yun, so fruit store, yung problems with finances due to pandemic restrictions, tapos yung medyo nagkakautang na siya dahil doon. Yan. So sa education, okay naman, and medical yun, like yung healthcare na may relative din siyang nurse na kasama doon, na malapit doon sa bahay nila. Yun. So family lifeline. So 2011 they adopted their daughter. So yun. And then 2014, patient husband was diagnosed with CKD and started on dialysis, and neck pain already noted. So nang namatay yung husband niya rin, yan mas grumabe, tapos yun yung mga income loss from the pandemic, tapos yung sa history of fall din, sumakit din daw. So yun. So yeah, impact of illness, the impact phase, reaction to diagnosis, and family diagnosis, nuclear family with young children, stage 2 of impact of illness trajectory, moderately dysfunctional with moderately inadequate family resources. And for the intervention, for patient education, continue maintenance medication for current condition, and pain medications for knee pain and knee pain. And monitor compliance medication and diet, continue working with rehab physician for therapy, and schedule family or the closest patient po is nga po walang ibang family, only yung close relative lang na nearby sa bahay nila. Probably my plan would be to have a meeting with them to discuss patient's problem and to explain to them yung problem ni patient. So yun. And wellness plan for the index patients, so the usual cervical cancer screening, breast cancer-related cancer risk assessment, HIV screening, hypertension monitoring, depression in adults. So yun, flu vaccine, weight loss to prevent obesity-related morbidity in adults. For the daughter naman yung usual vaccination lang din. And, ayun na pala. Thank you po. Yun lang po.
Thank you, Doc Ferds. Parang kung ano yung linakid ng family nung kay Dr. Jem, yun naman ang niliit ng family natin ngayon, ano?
Opo, Doc.
Okay. Doc, pwedeng ibalik mo dun sa genogram? So parang ang isang family lang, I mean, sa parents niya, so yung father niya may dating family. Okay, 3 generations siya, pero mukhang hindi lumitaw yung sa side ng mother niya. Tama?
Yes, the same question.
Okay na.
No, so I think maganda rin kasi syempre lalo na one of the functions of the genogram is also to give us an overview of the possible family ano tawag dito, family history, kasi di ba nakikita rin natin yung mga medical problems within the family at saka yung mga heredofamilial diseases makikita rin natin. So I think though you were able to do 3 generations, I think it would have also been beneficial kung yung sa side din ng mother niya nakita natin. Ang 34 yung mother niya namatay for for bone cancer.
Bone yes po, Doc.
Okay. Ang aga namatay ng mother niya no? Okay.
Yes,
Okay. Tapos what was the reason na in-enroll mo yung ang patient si Marisa as sa family healthcare?
Yung for monitoring, Doc, since meron siyang yung hypertension, dyslipidemia, yung mga chronic illnesses, tsaka obesity. So just to monitor and to help the patient also, Doc, na ma-retain niya yung pag-take ng medication since non-compliant siya initially dun sa mga gamot.
Because of non-compliance. Okay. Then, were you able to dig in ba for the reason of non-compliance?
Opo, Doc. Usually, Doc, the usual yung kahit tulad ng iba na since wala na siyang nararamdaman, nag-i-stop siya. Yung mga ganun, Doc. So, yun talaga.
Tapos next question ko kasi, meron kang schedule family meeting dun sa wellness ay dun sa family wellness plan mo. Kung titingnan ko tong genogram, sino pa ang ifa-family meeting mo? Tsaka what would be the reason that you want to meet the family? I mean, in what way could they help you address yung problem ng patient?
Dun yung kasi yung relatives ng patient close naman din sa kanya. So I think malaking tulong yon para mapaalala lagi if ever yung mga medications niya, tsaka kung may mga questions siya, mas matutulungan nila, tsaka assistance na rin regarding sa patient. Since yun nga recently din po, Doc, is nagkaroon siya yung sa niya, yung sa tuhod niya, mas lalo siyang nahirapan. So I think mas makakatulong yun.
Okay. I think nagawa mo ba yung family UpGuard 2?
Ay, wala po, Doc.
Oo. Kasi if that would be your reason, maganda rin natin nagawa yung family UpGuard 2. Kasi if I'm not mistaken, ang advantage of having also the UpGuard 2 would also identify other people no, aside dun sa immediate family niya or sa household niya, who could also help or provide assistance sa patient. Lalo na you had a plan of family meeting, it means na syempre ang imi-meet mo, sabi mo yung mga close relatives, of course yung relatives na pwede mo maging therapeutic ally, okay, in that sense. So I think kaya ko lang din nasabi yon kasi baka dahil naging part, baka ginawa natin tikahon na yung kasama ng wellness plan is to have a family meeting. Syempre pag kami family meeting, there should be a direction kung bakit mo imi-meet yung family. At saka for this case, sino yung imi-meet mo, since na ang makikita ko lang na parang ito ang nakikita ko lang na buhay na kasama niya is yung adopted child niya. Tapos hindi pa niya alam kung sino yung mga kapatid niya sa father niya. Tapos wala na rin wala na rin ng both parents niya. So kung hindi man lumitaw to sa genogram, we could have included it dun sa family app card too, kasi 'di ba dun lilitaw kung aside from the family kung kanino siya humihingi ng tulong or sino yung mga ibang parang nagsa-source out siya kanino aside from the family members. Okay?
Yes.
So, any other questions from our consultants or from our residents?
Hello po, good evening. Hello, Ferds. Si Dr.
Hi, hello, Doc. Yes, Doc. Good evening po.
Okay, so Ferds, dun sa report mo, no? So first of all, no, congrats, tapos ka na. Some comments lang, no? So, dun sa, could you go back? Anyways, dun sa mismong HPI, no? Okay naman yung mga PQRST mo, ganyan. I'm not sure lang, sige.
Balik po, Doc.
Yan. So anyways, yung question ko is, nilagay mo siya as musculoskeletal pain ba? With psychosomatic component. Tama ba? Bakit with psychosomatic component?
I'm thinking, Doc, usually kasi yung pain niya, yung nun sa family lifeline, tinanong namin, mas pain nung may mga stressors or parang stress dun sa na event na nangyayari. So, kaya nag-isip ako ng...
However, dun sa HPI mo kasi hindi siya...
Ay, walang nakalagay. Yes, yes.
Like exacerbated by stress or parang meron ba siya doon? Like, ganon. Nagtaka lang ako na biglang may ganun kasi siya. Pero kung if you go back to your history, parang hindi, wala naman siya doon, no? And then, ilagay nyo rin yung paglalagay kayo ng hypertension, syempre kung controlled, uncontrolled, mga ganyan.
Yes.
No? Ayan. So, and then, why do you give eperisone for this kind of pain? Nasa CPG ba natin ang eperisone? Or are there RCTs or systematic reviews saying that it will help in like musculoskeletal pain or strain ang eperisone? Hello?
Ay, hello.
Sige. Ano lang, concern lang ako kasi, well, sinasabi mo na medyo dun sa bandang part ng ano mo kasi, gitna, sabi mo may financial difficulties na sila, ganyan. So, syempre, you want to give medications that the patient really need. And yun nga, hindi na siya sobrahan pa ng meds na baka hindi naman pala beneficial sa kanya, magagastos din siya. Parang ganoon. So, ako kasi, I'm not sure, hindi pa ako nakakita ng CPG na nagsasabi na may effect yung eperisone sa muscle pain or musculoskeletal strain. Dun sa mga ibang mga parang muscular disorders, meron siya. Pero, or neuromuscular disorders, oo. Pero, yun nga, kaya nga tinatanong ko if you have seen Kasi ako personally hindi na yon CPG or RCTs or systematic review saying that eperisone could, have an effect, no? Ayun. So, yun lang. So, remind ko na lang na parang especially for our patients in ONA na medyo kapos ng pera, ganyan, mas maganda sana kung ano yun, prescribe yung mga cost-effective drugs. Okay?
Yes,
And then, sige, down nga tayo. Yung iba naman kasi binigay naman nung yung chondroitin sulfate sa si ortho na yun. So, okay lang yun. And then, ayun. So, dun sa, yun nga, nagtaka din ako like dun sa question ni Dr. ni Sibal, no? Why did you yun nung tinignan ko kasing map, yun nga, bakit mo siya in-enroll? Tapos yung sabi mo is because non-compliant yung yung patient. Pero non-compliance, kung non-compliance yung problem kasi niya, no, we could address that through individual counseling lang actually, 'di ba? What made you think that parang kailangan talaga ng family dito? Parang ganon. Kasi we could follow up individual patients naman, 'di ba? Pero may mga patients tayo na yung buong family yung ating ipa-follow up. Yun yung mga nasa family healthcare program. So, ayun. Kasi kung non-compliance lang, siguro ang una sigurong nangyari dapat is CEA, 'di ba? Individual CEA to determine kung may misperception nga siya regarding the disease or regarding the therapy para ma-address yung non-compliance. And then yun nga, nagtaka ako, yun yung dahilan ba? Ano ba yung yun? Tapos sabi mo, ano nga ba? Yung dahil may relative siya na close sa kanya, tama ba?
Yes, Doc.
So, yun yung gusto mong isama din sa healthcare program.
Opo, Doc.
So, parang gusto mo siyang gawing alay para matulungan.
Para ma-assist yung patient, Doc.
So, sige. So, sinong particular relative to?
Doc?
Sino yung particular relative?
Ay, Doc? Cousin, Doc.
Cousin niya. So kung ganon, tulad ng sabi ni Dr. Sibal, so yung Apgar 2 and kung talagang parang close talaga siya sa kanya, like do they live close together or palagi ba sila nagkikita nun?
Yes, Doc. They live close together, Doc, mga 3 blocks away lang. Tsaka yun, Doc, nagkikita naman sila everyday.
Kasi kung ganon, your family map should include that person.
Okay.
Parang siya, kasi yung iba,
dito.
Ayan. Kasi yung iba patay na sila, di ba? So, essentially, ano pa yung sense nung, I mean, hindi mo na sila maggagawang tulong dun sa patient kasi patay na sila, di ba? So, dapat yung enroll natin, syempre, yung mga living relatives, no, na makakatulong dun sa patient. Or yun nga, kung hindi nakakatulong sa patient, i-encourage natin na tulungan yung patient. Pero in this case, sabi mo, nakakatulong. So, yun, dapat siguro yung sa family map.
Include sila doon.
Include yung sino yung pinaka-feeling niya is parang family. Well, family niya naman kasi technically cousin. Pero yung close na close siya na parang kapatid na. Ganon. No? So, part siya ng family pa rin, nung core family, bali parang nung patient. Diba?
Okay, Doc.
So, ilalagay siya dun sa family map para mas makita namin kung sinong ini-enroll mo. Kasi pag ganyan, parang, for si Marie lang, tsaka yung si Angeline, ano magagawa nung bata? Parang gano'n.
Yes.
Unless may dysfunction yung sa kanila silang dalawa na relasyon at kailangan ng care yun. Yun yung pwedeng sila lang dalawa, di ba? Pero, ang sinasabi mo kasi gusto mong maging katulong yung isa pang cousin, so ilagay mo si cousin.
Yes, Doc.
And then yung pag ganyan, yung boundary lines between may boundary line between generations. So usually parental and yung ang tawag doon, yung child, 'di ba? So may boundary lines yung clear, ganyan, 'di ba? Rigid or diffuse. Ayan. So usually may ilalagay tayo dun sa
Pala.
ganoon. No, pause. Yun nga, siguro for the benefit of the other residents, mas maganda sana if when you present a family case, you present a family wherein you did a family intervention. No? Like, ano bang family intervention na pwede? Like, nag-family CA kayo kasi parang may misunderstanding yung family regarding the disease, and because of this misunderstanding, hindi natutulungan sa therapy yung patient, mga ganon, or may dysfunction dun sa family that affects, and then you did counseling, like intentional counseling for marital couples, ganyan, or kahit yung simple lang na motivational counseling, like ano yan, for families na halimbawa lahat sila pala hypertensive or diabetic tapos or obese, ganyan. Tapos yung eating habits kasi talaga nila yung may problem, no? Lahat sila mahilig sa ayun, ganon. And then so you do like a motivational counseling for all or as a group for the family to help actually the patient and actually lahat, buong pamilya na. So mga ganon. So usually when you present family case, naghahanap kami. Kahit sa PFP, maghahanap talaga sila nung anong ginawa mo dun sa pamilya, no? Anong intervention yung ginawa mo for the family. So in this case, parang wala pa kasi, no? Parang more of binigyan mo siya ng gamot. So that's an individual level, di ba? Binigyan mo ng gamot or in-educate mo siya regarding the disease. Individual intervention pa rin siya. No, hindi pa rin siya parang hindi siya family. And we do not simply present sa family case na yung mga family assessment tools and then family wellness plan, that's it. Actually, the meat of family case presentation is the family intervention itself. Parang ganoon. No? So, sa susunod sana.
Yes, Doc. Yes, Doc.
Pero
Yes, Doc.
Pero yun nga, in terms of yung presentation ng clinicals nung patient, yung history, PE, no? Concise naman and relatively complete. So that's maganda, no? So ano pa? So and then last thing na lang. Maganda kasi I mean yung PowerPoint mo, no? Maganda siya in such a way na hindi paragraphs yung nakikita, bulleted, ganyan, hindi ganun ka cluttered, no? Maganda siya. But siguro, mas maganda kung mas lakihan mo yung font, no? Kasi yan ay for presentation, nasa dulo ako, maliit siya, no? May mga slides ka na ano naman, maraming space pa. Para so, yun lang. So, congrats for presenting this case.
Thank you, Doc. Salamat po.
Okay. Thank you, Dr. Abby. Agree ako dun sa kung pwedeng lakihan ng konti. Total, marami ka pa naman space. Medyo hirap din. Oo. I could imagine kasi ako, medyo bata-bata pa. Baka sa mga seniors natin, medyo hirap. Anyway, joke. One of the things that I was thinking kasi baka yung dahil we follow the format of the family cases of those ahead of us, baka nilagay natin doon yung ganitong approach like family meeting. We also have to look dun sa family case nyo kung yun nga ba ang talagang kailangan ng patient, no? Not kumbaga sa clinical, we always say hindi natin dikahon. So also in your family case, you look kung ano ba talaga yung kailangan nung family niyo and what intervention you could give as a family physician. So thank you I think that was clearly pointed out by Dr. Abby. Any other comments po from our consultants and residents?
Good evening.
Hello. Oo, sunod ko. Hello,
Hi.
Dr. Goldie. Oo.
Dr. Irene?
Actually, congratulations, no, Doc Perds, and napaka ano din yung mga comments ni Doc Abby tsaka ni Doc Goldie, halos kompleto na. I just want to comment on the clinical part, yung dun sa medication ng patient. Oo, kasi 'di ba non-compliant itong patient na to. So
Yes, Doc.
alam natin na hindi siya nagte-take ng medication. So ilang beses mo kaya siyang nakita? Sa ER lang ba or second time ganon bago ka nag-adjust ng medication niya? Kasi
For this, opo, Doc. For this, ano po, Doc, first pa lang po siya, Doc. Itong
Oo.
bigay ko, Doc.
Okay, kasi kung non-compliant yung patient, baka pwedeng ibalik muna yung dating medication, then BP monitoring bago mag-adjust. Then usually kasi di ba
Yes, Doc.
try muna natin para hindi na rin mahirapan yung patient sa pag-inom ng maraming tableta, maraming klase. We
Opo.
adjust one medication first, i-maximize. Tapos kung hindi pa rin pwede yung yung isang drug like yung hypertension, no, amlodipine 5 lang siya before eh. Tapos ngayon nag-add ka kaagad ng 50 milligram. And baka nung time na nakita mo rin siya, in pain siya, so meron din yung effect sa hypertension niya. Siyempre,
Yes,
nililimit din natin yung polypharmacy sa mga patients, tsaka yung additional burden, no, yung price ng mga medication. Tapos, gano'n na siya katagal nag-a-atorvastatin, no, 40 milligram, no. So, kung April yan na start, no, we can sa follow-up niya pwedeng mag-request ng or yung plano mo
repeat.
naman talaga siguro yan, 'di ba?
Yes,
Then
Doc.
we check also kung may mga liver problem or may effect sa mga
Yes, Doc.
muscle kasi osteoarthritis to, baka may mga muscle pain then secondary to the statin, no. And
Doc.
yung sa naman pain reliever, tinanong mo ba kung ano yung usual na tinitake niya for pain? Parang wala, no? Yun ba yung
Yung ano lang, Doc, Efenamic, Doc. Usually yung tinitake.
Metformin.
Yes, Doc.
Okay. So, actually, sabagay, choice mo naman yun, no? So, pero from NSAIDs, mefenamic, baka gusto mong mag-change to another non-steroidal na mas effective sa inflammation, no? Kasi paracetamol is usually antipyretic, no. Yung niya, yung anti-inflammatory effect niya usually nag-increase lang as you increase the dose, no. So ang paracetamol tramadol has only 375 milligram. And tramadol din, siguro kailangan nating i-observe kung magkakaroon ng epekto sa patient kasi nagko-cause siya ng dizziness, no. Lalo na mag-isa lang ito sa bahay.
Opo, Doc.
9 years old lang yung kasama niya. So, iwawan din natin sila. Yun. So, kung may better alternative na medication, kung okay naman ang kidney function, so pwede naman tayong mag-NSAIDs or yun.
Copy, Doc.
Yun lang siguro.
Thank you. Thank you, Doc.
Thank you, Dr. Irene. I think yung teaching pearls doon is for our patients na nagpa-follow up or nakita natin, then nag-follow up lalo na if non-compliant, maybe we should also check yun nga, baka kaya hindi nako-control yung hypertension dahil sa non-compliance. So parang before you give another medication, ang point ni Dr. Irene is baka i-try niya munang i-take yung unang medication niya. Okay,
Yes.
then also looking into the side effects, and also we go back do sa sinabi ni Dr. Abby na we keep on yung mga meds na binibigay natin, whether they were started by us or given by other doctors, maybe we have to review them for their for the benefit that they will give, lalo na kung wala naman evidence, tapos lalo na ang mga patients natin usually financially challenge sila. So, or hindi man challenge, talagang may problem sa finances nila. So maybe let's stick to the medications that has really proven benefits for our patients.
Yes.
Okay.
Yes.
Thank you, Dr. Irene. Congratulations
Thank you,
pala
Doc.
sa research mo.
Congrats,
We're
Doc.
proud of you. Any other comments po?
Good evening, doctors. Good
Good
evening.
evening, Doc.
Congratulations sa report mo.
Thank you, Doc.
Anyway, I hope you were able to take note of the comments of all your consultants, no?
Yes,
And
Doc.
be able to apply it to your other families.
Yes, Doc.
No, it's also a reminder to all the residents present here. So be aware kung ano yung criteria natin. Although sabi mo nga may chronic illness siya which is hypertension. So kung tutuusin, pasok naman yun doon sa isa sa mga criteria mo, no? Pero I think more than enrolling the family, tama si Dr. Abby, ang kailangan mo dyan is counseling.
Yes.
Kasi obviously doon pa lang sa sinabi mo, kailangan niya ng CEA. Kasi may misperception siya na klaro eh, di ba? Sabi mo dahil pag wala siyang nararamdaman, hindi na siya iinom ng gamot.
Yes.
Aside from the fact na financially constrained siya, nabanggit mo din kanina dahil sa pandemic affected yung source of livelihood niya, di ba?
Yes.
So, paano pa niya iinumin yung ibang gamot? So, may point din, pareho sila ni Dr. Irene.
Yes.
Anyway, for the benefit of the other residents, especially of our first years, ano-ano ba yung mga ibang criteria for admission of the family into the family healthcare program? Siguro yung ibang senior residents natin pwedeng tumulong. Aside from having a chronic illness, ano pa yung mga pwede nating maging dahilan? Criteria. And yung pagiging readily accessible ng family. Any volunteers?
Doc, dapat willing yung family, yung patient and family to be enrolled in the family case.
Yes, so yun, pasok yun dun sa pagiging accessible and cooperative na family. What else? Sige, pag halimbawa may family dysfunction, di ba? Kapag if you are presented with a rare condition that possesses or poses a diagnostic dilemma, or simply kapag very interesting yung kaso ng index patient mo. Meron pa bang iba? Dr. Abby, kompleto na ba? Yung criteria?
Actually, sir, sorry. Yung sa amin lang kasing criteria is, if you think that, personally lang, ay sa lang, sir, hindi siya nakasulat. Sorry. Pero sa amin, it's like, you enroll the family if you will, the family members could help in the therapy of the patient, or there's some dysfunction that should be addressed para matulungan sa yung management ng patient, parang gano'n.
Pwede din ba na wala nung mga hindi siya interesting case, walang chronic illness in any member of the family, walang diagnostic dilemma, pero cooperative lang sila at gusto mo lang i-promote yung wellness ng buong pamilya?
Well, actually, yes, sir. Pwede naman po. Kaya lang, kung wellness, parang more of may gagawin ka pa rin siya as a family intervention, like motivational counseling for exercise, ganyan. Parang gano'n. Pwede naman po yun.
Okay, thank you. Again, congrats, Doc Cards.
Thank you, Doc.
Back to you, Goldie.
Thank you, Doc. Thank you also for raising yung criteria for admission. Actually, I was looking also kung meron bang parang written black and white talaga kung ano yung criteria for admission. Usually, ang alam kasi natin either chronic diseases or yung more on dun sa kung merong family na in dysfunction na need ng intervention from a family physician. Yung may intervention kang gagawin sa mismong family. Yun. It was also good that it was raised by Dr. Abby at na-ask nyo rin, Doc Tai, yung kung halimbawa yung promotion of wellness, then I was thinking, oo nga, ano bang gagawin? At least na ano naman ni Dr. Abby yung motivational parang counseling. That is also a good point. Which is dito kasi sa atin, marang hindi masyadong nabibigyan ng attention yung health promotion and wellness. So that was a good ano rin, point that was raised. Okay, thank you.
Goldie,
Okay, Doc Nishas.
may sasuggest lang ako, no? Sa
Yes
mga
po, Doc.
residents na magpe-present next time, sana kumuha sila ng mga kasong maraming medical problems at saka merong psychosocial, no? Kasi this is a family case presentation. Tama si Dr. Abby, dapat may mapipresent kayong mga kaso na may involve lahat yung family because of the psychosocial problems related to the case, no? Ito kasing para ma-challenge sila, no? Kung itong kay Dr. Sanguyo, kung ipe-present mo to sa family case presentation, mukhang hindi siya, very simple siya, no? Hindi siya parang pang family case presentation talaga. Dapat tumahanap pa sila ng yung mga challenging cases, no? Yun ang impression ko.
Okay po, Doc. I think that was noted, no? Especially one of the functions siguro na we conduct family case presentation is so that we can see what would be yung biopsychosocial approach. Tama po ba, Doc? That is one of the very core natin, especially in our approach, the biopsychosocial approach. And that would be highlighted dun sa family case mo if yung case mo would require talaga na you have to dig deeper. Halimbawa, hindi lang siya simpleng case ng kasi kagaya nun yung ngayon, pwede siyang individual counseling. But we want also to see the psychosocial aspect, which is yung sa family. Kung sabi ko nga, that's why I was joking na yung una natin parang yung kay Dr. Jem, ang laki ng family, tapos ngayon parang biglang maliit, okay? But overall, this was a good presentation. At least we were able to see on the how we can develop more family cases better. May request po si Dr. Irene. I think maganda to kasi ang gusto niya multi-drug resistant TB. And more, I think Dr. Irene, if aside from her being the physician sa TV dots ng JBL. I think marami kasing psychosocial aspects ang causes ng multi-drug resistance. Tama po ba, Dr. Irene? And I think that will be a good showcase of an intervention by a family physician. Tama po ba, Dr. Irene?
Yes, Dr. Goldie, talagang matcha-challenge ka. So, actually marami tayong cases doon sa STC para kung merong magiging interested na resident. Actually, I think si Dr. Bernardo mayroon siyang tinitingnan na 7-year-old na MDR-TB na may PATS disease. Pero nilalagay niya siya sa interesting case. Pero marami pang cases doon na pwedeng kunin kasi makikita mo talaga yung dynamics ng ng isang family challenge with a family member na may MDR-TB. So magandang case talaga siya.
I think naka-admit pa rin yung isa nating patient, no, Dr. Irene, yung ni-refer sa'yo.
Yes, Doc, nag-i-improve na daw po.
Okay.
It's up to
Baka you might want to visit that patient sa annex. Baka pwede siya.
Yes, Doc. Or sila, Doc, may isang case doon na 17 years old na may MDR-TB na detect sa lymph node abscess. So maganda rin yung dynamics nung na yon kasi single mom tapos may children. Tapos ang naging index ng TB yung kasambahay na relative. So magandang case siya. Tsaka yung kung paano sila economically, kung paano financially, kung paano nag-struggle yung family. Pero marami pa rin doon.
Tanungin nyo lang si Dr. Flores.
Yes. Yes, do not be afraid to take on challenging cases kasi baka matakot sila na lalo na kapag MDR-TB medyo complicated yung treatment. And evolving naman kasi ang family case, tama po ba sa mga dear consultants natin? You don't have to solve everything in one sitting. Evolving siya. Ang maganda dyan is lalo na kung may blessing ng mga consultants natin yung pagkuha nyo dun sa family case. During family case presentation, there could be suggestions on how to manage the patients. More than the clinical, yung mga pwedeng psychosocial interventions na pwedeng gawin sa family. That's the beauty of presenting a family case. We all learn from the consultants to the residents.
If I may add also, no, para din sa lahat, magandang i-present na family case yung maraming beses nyo na silang nakita. So may mga family interventions ka nang ginawa and you'll be able to present kung anong effects ng mga family interventions na ginawa mo. So the moral lesson here is hanggat maaga, mag-enroll na kayo ng mga families nyo. So when the time comes na it's your turn to report, mas marami ka nang maipresent. That's all.
Thank you, Doc. Okay, so yun nga, yung you don't be scared na yung parang everything has to be done in one sitting. Mas maganda nga yung yung sinabi ni Doc Tay, yung nakikita natin nagde-develop una yung rapport nyo, yung relationship nyo with the family of your with your patient's family. Tapos makikita rin natin na through time ano yung developments that you bring into the family because of your presence as a family physician. Okay? So I think that was that is the gist of that. Okay, so don't be afraid na to take on ganito yung mga challenging cases. Any other comments? Okay. Sige. Doc, meron po ba tayong mga announcements?
Yes, hindi naman. Yung with regards to the activity dun sa recap, dun sa research, yung topic kasi bukas, parang na-discuss na yun last year eh. So yun ang sabi sa akin ni Sir Emil. So I think na attendan na yun lahat ng mga more senior residents natin. So baka next year na lang tayo mag-participate dun sa mukhang every year naman inuulit nila para dun sa mga first year natin ngayon. And then I would like to get your input para ma-solve na once and for all yung sa gray area ng OB natin, no? Kasi ang challenge natin ngayon actually is talaga yung staff na mag-a-attend, no? So I think ang ginawang dati ang gray area natin is yung sa tapat ng NICU. Tama ba?
Yes po, Doc.
Yes po, Doc.
Tapos ngayon parang nilipat doon sa may station 4, yung mga may cubicle, yung parang isang yung parang ward doon. Tama? Or doon pa rin sila sa tapat ng NICU? May nakikita pa rin kasi akong dinadala doon sa tapat. Ha?
Sa tapat pa rin siya ng NICU, Doc.
Oh, okay. Pero sino na ang nag-a-attend sa kanila pag nandun sila sa tapat ng NICU?
Clean case nurses.
Hindi yung midwives na nagpaanak.
Hindi, Doc. Ang alam ni na Ma'am Emma, yung midwife yung nag-a-attend. Kaya nga kaninang pinuntahan ako ni Sir Moy, nagulat sila na yung nag-a-attend itong mga clean case nurses.
Yun na nga eh. So, hindi pwede yun on that sa kasong ganyan kasi they'll be handling potential na COVID.
Kaya nga po, Doc. Yung po yung concern kanina, kasi syempre kahit yung residents na-expose din po sa ganon. Dahil binawasan nila yung duty sa OB, yung isa, nilagay na nila, pinupull out nila dun sa Malasakit Center, yung PUI. Tapos isa lang natitira sa OB, siya din yung nagme-medicate sa clean cases at the same time dun sa gray area. Kaya po hindi ko pinayagan nung una yung yung patient na may transfer doon, which eventually tinransfer din nila yung rapid antigen positive.
Okay. So what are your suggestions as a group? Ilalabas na lang natin sa tent.
Last time, Doc, pinakiusapan ko yung sa Malasakit Center na tignan yung sa gray area since
Pwede.
mga dirty cases naman ng hawak nila. Kaysa sa pahawak sa mga clean nurses, mako-contaminate yung clean area.
Sa bagay.
Yun yung immediate solution ko nung nagkaroon kami ng dilema kung sino magka-handle. Kasi may nag-positive yata na hindi mailipat-lipat. Tapos may rapid antigen positive na gustong ipasok to na hindi may pasok-pasok na may baby rin. So hindi mag-uwi. So kinausap ko yung sa Malasakit Center muna na sila muna mag-take over doon sa gray area. Since hindi naman ganun karami yung papasok doon. Saka marami naman sila.
So I guess we can suggest that kay Sir Moy.
Yes po.
Gawin na niyang policy para sa kanila.
Pwede, Doc.
At saka po, Doc, ang laki ng risk na makahawa din yung mga clean case sa nurses. Kasi sila, they have to perform their duties, no? Kasi hindi sila binibigyan ng PPE kasi sa CSR, sinasabi nila, clean case daw sila. So pumapasok sila ng gray area nang hindi sila naka-gown. So I make sure sa order ko, do not enter the area without PPE. Papakita pa lang nila yun sa CSR, baka bigyan lang sila. Kaya ang laki din ng risk na mahawa yung mga residents natin kung nag-intermix sila ng pasyente tapos hindi man sila binibigyan ng PPE.
Okay. So, siguro yun na rin lang ang magiging recommendation natin sa nursing service, no?
Siguro po, Doc. Kung talagang hindi may iwasan dahil understaffed, i-provide sila ng PPE.
Okay, sige.
Yung hindi sila ma-hassle sa paghingi sa CSR.
Basically kasi nagtitipid ang CSR.
Oo nga
sige.
po, Doc.
Thank you. that would be all muna. Pero with regards to the EBM reporting, siguro let's start in October. So, makausap ko na sina Doc Noreen and Doc Joser to do the first reporting. Schedule na lang natin.
Okay po,
Thank
Doc.
you.
Thank you, Doc.
That would be all, Goldie.
Okay, thank you po, Doc Tyrell. So with that, I think this session has ended. Before we go, Doc, kailangan natin ng picture taking.
Sige, matagal na tayo hindi nagkikita-kita sa Zoom.
Sino pong kukuha ng picture? Sino yung may laptop? Kasi pag akong kumuha ng picture, kami lang ni Doc, dalawang Doc Joser sa phone ko. Baka sabihin nila ka-video, ano ko lang ni Doc Joser.
Doc Ferds.
Yes, Doc. Ito na, Doc.
Okay.
Ay. Print screen. Ay, sandali, Doc. Hindi ka ako marunong. Ayan. Siguro na-record na, Doc.
Okay na?
Check ko lang, Doc. Ayan, Doc. Meron na.
All right. Thank you, everyone.
Okay, Doc.
See you next week.
Thank you po.
Thank you, Doc.
Thank you. Stay safe.
Thank you po.